All right, Dr. Stewart. Now, before we begin, if you could just give our viewers a brief background on who you are, and then we can dive into questions.
Hi, I'm Paul Stewart. I'm a professor of medicine and endocrinology, and I'm based at the University of Leeds in the United Kingdom. I'm also editor-in-chief of the Journal of Clinical Endocrinology and Metabolism.
All right, thank you for that, and thanks again for joining us. And the first question I think that comes to mind before we talk about this editorial in the journal is, who do you think are the highest risk patients for endocrinologists right now?
Yeah, I don't think we fully know the answer to that question yet. What we do know is that when you look at the series that are emerging of patients who become particularly unwell, and sadly those that are dying from COVID-19, then patients with diabetes mellitus are overrepresented in that group. That may be just a factor of age, because with that also goes other comorbidities, particularly patients with cardiovascular disease, previous cancers. So this may just be part of the age-related phenomenon that we're seeing in terms of mortality being higher in elderly subjects. But on the contrary, it may be that for whatever reasons we don't fully understand yet, if you do happen to have diabetes mellitus and you fall ill with COVID, then it may be a more severe infection in that group.
All right, thank you for that insight. And now let's touch on this editorial and why patients receiving glucocorticoids are among the highest risk patients during this pandemic.
Yeah, so this is really important. So as endocrinologists, we see patients who have both underlying adrenal disease, Addison's disease, adrenal failure, and also patients who have secondary adrenal insufficiency because of usually disorders of the pituitary gland. So these are relatively rare conditions. By rare, I mean, affecting less than 5 per 10,000 patients in the background population. They're usually under the care of endocrinologists, and we know about them. And the majority of these patients are well educated. They're treated with physiological doses of replacement glucocorticoid. And just with any other intercurrent illness, they know to double their dose of glucocorticoid in the event of fever, or in this case, also other symptoms of COVID, particularly a continuous dry cough. So that to me is a less risky group, because we know about those patients and we anticipate that they will be maintaining their usual sick dose, their sick daily rules. Obviously, if their condition deteriorates in any way, then they need to seek urgent medical help, because they may need parenteral steroids. The group that's slightly more worrying to us are the patients who are treated with pharmacological doses of glucocorticoid. And we estimate in the at-risk COVID group, this might be as much as 5% of that particular patient population. As we know, these are patients who are taking pharmacological doses of glucocorticoid for underlying inflammatory conditions, be that inflammatory bowel disease, rheumatological conditions, polymyalgia, and patients with asthma. And the studies that myself and my colleagues and others have been involved in have shown that up to 50% of those patients have an impaired adrenal response to stress. They don't mount a normal physiological cortisol response to an infectious illness. And it's that group that we're particularly concerned about.
And now it seems that just about every single part of this planet at this point has been impacted by some sort of stay-at-home order or quarantine or lockdown. How is the outbreak impacting outpatient practices of endocrinologists?
Yeah, I mean, I think this probably differs in different countries, Patrick. Certainly in our country, many physicians that are involved in the care of patients with endocrine and diabetes disorders are also general internists. And obviously there's been quite rightly, in many ways, a huge shift in emphasis as many of us are now doing so-called, front door acute work. And many of us are putting back our elective, more elective outpatient work, deprioritizing that. There's many of us that are working from home, that are doing telemedicine clinics from home and keeping in touch with our patients. And I think that's a similar practice as well going on in many other countries, as we ourselves are taking on board, the need to socially isolate and take responsible measures ourselves. So I think you'll find the practice differs in different countries, but certainly it's having an impact on the normal, routine follow-up of many of our patients with endocrine disorders.
All right, thank you for that. And now, do you mind really quickly just sort of expanding on how the use of telehealth might differ for endocrinologists compared to what you think it might be like for other fields?
Yeah, I think particularly as increasingly we've tried to encourage a more holistic approach to the care of patients with diabetes across primary community care providers and secondary care. Then many of our patients are becoming very adept at the use of health technology aids, particularly digital and data devices. And I think we've seen those, the maturity of those accelerate with pace. And of course, now we face what some are describing as a burning platform. These are coming to the fore as being a really useful aid and tool in terms of helping us manage these patients. I'm very fortunate in working in a hospital that's got a very developed electronic health record that spans primary and community care as well as secondary care. And that's making the management of patients an awful lot easier as well in terms of doing telephone clinics and remote consults.
All right, and I know the editorial really focuses on patients receiving glucocorticoids. Are there any other therapies that might have adverse interactions with COVID-19, like say SGLT2 use, that you might condone against use during the ongoing outbreak?
So I do want to come back to the patients I referred to who are taking exogenous glucocorticoids, therapeutic glucocorticoids, because I have a particular concern that we as endocrinologists need to be flagging to our colleagues in intensive care. So remind me to come back to that. But the point you make is a really valid one, and there are many reports out, particularly you'll have read around the use of angiotensin converting enzyme inhibitors, angiotensin receptor blockers, with actually, results either way. Does this actually make the impact worse? Does it make it better? I think the guidance, which has certainly come out from American Heart Association and endorsed by international recommendations this side of the Atlantic, is that these are preliminary reports and we should not be changing patients' medication at this time. That's certainly true for cardiovascular related medications, and I think it's true for diabetes medications as well. So these are important things that we need to watch as we get further experience. Published reports, scientific evidence will emerge, but for now I wouldn't recommend any changes at all without expert physician advice.
All right, and then you wanted me to remind you to touch on
Yeah.
patients receiving glucocorticoids.
So I think this is the really important issue, and it's potentially confusing because the WHO quite rightly have said that glucocorticoids for the use of patients with COVID, particularly in the context of those developing ARDS, there's no added benefit at all. In fact, if anything, outcomes might be slightly worse. So none of us here, it's very important, we're not advocating glucocorticoid therapy, parenteral glucocorticoids in that context. The exception to that are patients who have previously been exposed to pharmacological doses of steroid, as I've said. And he's always simply trying to highlight in this editorial and I think it's a good take-home message, is there should be no patient at all who falls into that group who's deteriorating on an intensive care unit, where intravenous glucocorticoid therapy should not be considered. Not in a kind of therapeutic way, but simply to replace the normal stress doses of steroid that any of us would be under in that situation. And that to me is the take-home message. We really need to get that over as endocrinologists to our acute intensivist colleagues. Always think of glucocorticoid in that particular patient scenario.
All right, thank you for that insight. And now really quickly, I wanted to touch on a patient-centered question. Obviously, like you said for our previous question, it's a little bit different depending on where patients live, but what do you think the state of concern is about COVID-19 among diabetic patients?
I think it would be premature for us to be giving any kind of concerning messages or guidance that was different from that of the general population at this stage, which of course is to self-isolate where necessary and take adequate measures for social distancing. Um, my own personal belief is I don't think just having diabetes mellitus per se puts you at increased risk of having a COVID-19 infection. Quite what this relationship is when we start looking at those in the elderly subjects, the overrepresentation of diabetes mellitus in patients who are becoming particularly unsick and in deaths, I think we have to explore that. So in hospitalized situation, we would just signpost, I think, to all medical teams, I'm sure this is happening now, that if there is an underlying diagnosis of diabetes, just take extra vigilance. But I don't think that at the moment that needs to translate into any difference in terms of patient of direct patient guidance. I think for those who are on glucocorticoid, I think we've largely been through that and covered that off, and I think that that is very clear for the patients we know about who are on replacement doses of steroid for Addison's disease and pituitary disease.
Is there anything that we can see about the interaction between the mechanism of SARS-CoV-2 and diabetics and non-diabetics that you can touch on?
Just pure speculation at this stage, but what's really exciting for me as a clinician scientist, and certainly you'll have seen the way I think that we're addressing this head on in the United Kingdom, is the realization that it's a very strong science, innovation, evidence-based approach that is going to get us through this. Hopefully, many months down the line, vaccines, but obviously before then, an immense amount of effort that's looking at novel candidates, novel targets, to see if we can have an impact on the disease. And as an endocrinologist, I'm excited that at least some of the mechanisms by which SARS-CoV-2 is transmitted, infecting cells transmitted through the body, are endocrine-related mechanisms. So the link with angiotensin converting enzyme 2, which appears to be the cellular signal by which SARS-CoV-2 is taken up by cells, I think is particularly exciting. And then from that, the suggestion that some of the downstream signaling pathways, we might have selective inhibitors against those that could quite dramatically impact on the transmission of the disease, I think is exciting. And those trials I know are underway. Those were certainly, I'm aware of that they're underway already in the Far East. And I'm sure are being taken on board here in Europe and North America.
All right. And now, how do you think that COVID-19 has impacted the dissemination of information in medicine? A lot of conferences have been canceled recently, and a lot are going virtual, but we've really seen an impact as far as the dissemination of information goes. And what do you think the impact of COVID is on endocrinology outside of day-to-day practice?
Yeah, this is a really good question, and just in recent weeks, I've been aware of initiatives which are now truly global, where we collectively coming together to offer greater support to particularly our trainees in endocrinology. As I've said, many of them have also been diverted to more frontline, acute work, and they're requesting us to make sure that we can do our utmost to keep their ongoing clinical accreditation and training in endocrinology diabetes up to date. So I think just as we're doing in a university setting, many of our undergraduate courses, there's been this amazing proliferation of online education resource, and many of us are now on that line very much with postgraduate taught education to endocrine trainees. I'm sure you're aware of this, but although the face-to-face meeting in San Francisco for Endo 2020 was cancelled, there's already some really exciting developments in terms of having the content of that online. and as an editor-in-chief of one of the flagship journals for the Endocrine Society, I want to make sure that that the journal plays its part in that as well, in terms of conveying that educational material. So I think we're adapting. We're obviously missing the direct social interaction. We're very sociable individuals, and we're all really missing that. But we are providing alternatives, I think, very rapidly in that space.
Okay, thank you. And my last question, how do you think the lasting impact of COVID-19 will affect endocrinology practices as we move along and get past this outbreak?
Well, I think it was your own John F. Kennedy that reminded us that through every crisis comes opportunity. And I think we're already seeing that certainly in my sector of research, higher education, as I say, rapid proliferation of online materials, immense change programs going on across everything we do. And certainly in clinical practice, I think there's probably, as we look inwardly and reflect on this, when we're out of the crisis, I think we've all learned to do things, differently. One of my kind of real bugbears has been, that we need to increasingly move to a patient-centric care pathway rather than what has historically been a physician care pathway. And you've touched on some of the great technology advances that are helping us do that, in a matter of weeks, literally, rather than the months and years that it might have taken without us having this crisis situation. So I think it will be important that we don't go back simply, picking up where we were pre-COVID. That we do learn from this, and so I can certainly see advantages in that. Do I really need to see every patient that I've currently been seeing in an endocrine outpatient when I can empower and equip them with the technology to manage that what's a chronic disease far better in a community setting? And we will learn from this, definitely.
All right, thank you. Is there anything else you wanted to add?
Well, I think, just that the population at large is immensely grateful of the personal sacrifices where you and are all making in this space, and a big thank you for me, as a fellow endocrinologist, for stepping up to that plate. It's really important we do so at this moment in time. Please don't forget the steroid-related bit in this, because I think if we can get that messaging right across intensive care, it will save lives. I've estimated in the UK alone that maybe as many as 1,000 people who are going to come through intensive care units who've been previously treated with pharmacological doses of steroid. Is going to be a far higher number than that, obviously, in the USA. So keep that at the core. But we can all make a difference, and we all need to make a difference right now.
All right, that's it from my end, Dr. Stewart. Thank you again for your time. Really appreciate your insight.
Thank you, Patrick. Take care.
Not a problem. Have a good one.